All right. Well, welcome to our webinar tonight with Woo You. I'm with Dr. Cecilia Ketting. Thank you so much for being here tonight. And we're going to talk about the most promising treatments in the OSD pipeline. Super interesting. Love learning from you. So thank you. And thank you to our amazing audience for being here as well. Next slide. I'm your host, Dr. Lise Kramer, currently in Miami. Dr. Ketting, where are you at?
I'm actually in St. Louis, Missouri today.
Okay, very nice. Our little jet setter.
Yep.
Next slide. And thank you to Tea Pharma for exhibiting at this event. So a few housekeeping items before we get started. For each hour of CE units, attendees must be online for a minimum of 50 minutes. This is a 1 hour CE course, so you must be online for a minimum of 50 minutes in order to get your CE credit. For a COPE certificate, please fill out the survey link in the chat. Also, the survey link will appear when the webinar ends. CE certificates will be delivered by email and sent to ARPA with OE tracker numbers, but there will also be a QR code that we're going to display at the end of the event. So if you have the OE tracker app on your phone, you can use that to get instant CE, but you can't use the camera that's on your phone. You actually need the OE tracker app. If you don't have the OE tracker app, it's fine. You will still get your CE certificates by email within 4 weeks. You can ask questions using the Zoom on-screen floating panel that you see there circled at the bottom. There's the chat where we like to keep the logistic items for questions, and the Q&A. If you have any questions for Dr. Ketting about the presentation, we recommend that you put them there. Next slide. If you're using the mobile version of Zoom, you'll find the Q&A at the top. And if you want to ask questions in the chat, you can click on the 3 dots you see there at the bottom to have more options, and you'll find the chat there. So I will introduce Dr. Ketting. Dr. Ketting practices at the University of Colorado School of Medicine in the Department of Ophthalmology in Denver, Colorado. Her primary focus is in anterior segment and ocular surface disease, neurooptometry, and perioperative care. She partakes in clinical research and has served externship director and adjunct faculty for several schools and colleges of optometry. Dr. Ketting is a member of Intrepid, a fellow in the American Academy of Optometry, a diplomate of the American Board of Optometry, an active member of AOA, and has served as both local and state officers within the AOA. She was named Young Optometrist of the Year by the state of Virginia, and Dr. Ketting lectures locally, nationally, and internationally at conferences, continually contributes articles, and serves on editorial board for multiple publications. Having heard her speak, she's amazing, and I'm sure you will all learn a lot. So thank you once again, Dr. Ketting, for being here, and I'm looking forward to learning from you.
Absolutely. I'm so excited. I'm going to have this slide up again here in a moment, but those are my financial relationships. All have been mitigated. I love speaking to the Woo You group. Everybody who's a part of this audience who continuously shows up for these CEs, you're phenomenal. You're great. Please keep asking questions. I love questions. I will answer them if you put them in the Q&A as I can as we're going through, just so it's a little bit more organic and it also is a little bit more interactive for me. But we are here talking about the most promising treatments in ocular surface disease pipeline. And I think it's important to keep talking about this. We know we've had so much that has actually come to fruition in just the last year, right? And we'll just kind of touch base on those just a moment, right? But I want to talk about the other things that maybe we don't think of forefront that are potentially coming down the pipeline in FDA trials. Continue to be excited about and fill these little niches and these little voids that we have as far as for treating our patients. As I mentioned, all financial disclosures have been mitigated. And, let's start this off by let's talk about what is dry eye disease. And I think even more importantly, and I need to actually start to maybe do a whole lecture on this of like, what's the difference between when I talk about dry eye disease and ocular surface disease. And I really honestly probably use ocular surface disease more to discuss these things than just dry eye, because I don't think of I think of it as an all-encompassing, right? Ocular surface disease is dry eye disease. It's meibomian gland dysfunction. It's blepharitis. It's all this stuff that goes in there. And there's a lot of it that kind of commingles, and it's very rare that we have just one of these problems. TFOS dues 2 currently are revised definition as of 2016, which actually do 3 at the TFOS meeting. So we'll see if they revise it again. But I think the big thing to take away from this is, like I said, it's a multifactorial disease of the ocular surface characterized by loss of homeostasis of tear film and accompanied by ocular symptoms, including tear film instability, hyperosmolarity, ocular surface inflammation. We love that. We talk a lot about inflammation here. And that leads to damage and neurosensory issues, talking about like neurotrophic keratitis, right? And with it, we have to remember that all of these things are a progression. It is not, it is, we may find patients at one step or another, but it's very rarely that they didn't get to step, neurotrophic or neuropathic without going through the others. So it is important to treat those patients at all of those stages that we see them. And a lot of times it's better if we catch them earlier. So I love to ask this question when I lecture, as well as when I talk to even my patients, because they say, "Oh, who else has dry eye? Am I like special?" And I'm like, "No, who has dry eye? Everyone, everyone." And I get asked now that I live in Denver, do I see more dry eye living in Denver than I did when I was living on the coast in Virginia Beach? And I would actually say no. I don't. I see probably as much. Everybody's got it, right? I think that the patients are a little bit more symptomatic than they are when they're in Virginia, just because the environment's a little bit more humid, so they don't necessarily feel it as much. Prevalence of dry eye disease, I jokingly say everyone, right? But we talk about there's about 16 million people who've actually been diagnosed with dry eye disease, but that's the ICD-10 code, right? That's what actually has been coded in their chart. And it's estimated that about 33 million people suffer from dry eye symptoms. That means they haven't been necessarily diagnosed. That's a big gap that's right there. I think we'd all kind of probably say that jives with what we see in clinic. Even if we don't put it, we do, we may not use the diagnosis code, but we do talk to them about even using artificial tears intermittently, right? So what causes it? We know we've got lots of environmental things. We've got our systemic, we've got autoimmune, we've got all of these different things that go into it. Types of dry eye disease, evaporative or aqueous deficient. Well, guess what? They're not mutually exclusive. Like I said, most of the time we've probably got a little bit of both. Now, today we're not really jumping in how to determine what the underlying cause is and how to diagnose. We're really talking about the treatments that are coming. We will talk about a couple of new diagnostic tests that are out there. But I think it's good just to remind ourselves, how to differentiate and have a better understanding of maybe what some of these treatments would be better adept to one patient versus another. Slit lamp. Who doesn't have a slit lamp? If you say you don't, then I'm not sure if you're in the right lecture, but it's okay. I'll hear you out. But yes, we all have a slit lamp. And you got to use vital dyes. I know. I've had people tell me, but I can see it without a vital dye. You're right. You can when it's really, really bad. Think about all those patients that you might be missing if you're not putting fluorescein on there, who may be at that very subclinical or very early, or that patient who may be having complaints and you're just saying, well, you look okay, but actually, in fact, they really do have some dryness. So it's important. And when we're looking at that, you have to remember to look at the pattern, the location, the severity. And that can help us understand what a patient's underlying cause is. Don't forget about a Ratten filter. I have one in my pocket that I got off of Amazon. I'm not plugging Amazon because Jeff Bezos has enough money, but great place to just pick one up that's pretty inexpensive. You can put in your pocket, but I definitely even pick up that much more when I'm using it. And then don't forget about Rose Mangel. That's a really good way to help kind of differentiate between HSV, looking at our dendrites versus our patient who may actually have just a very irregular stain of dryness, patch of dryness. Lid and conjunctival staining, lissamine green. That does, again, give us more information that is going to kind of give us an idea. So if you see conjunctival staining on the inferior portion of the conj, maybe they're sleeping with their eyes are open or partially agape, or they've got incomplete closure. If you see it more nasal, that can tend to be somebody who, again, is sleeping with their eye a little bit agape. They're not getting good closure, like my husband. So it is good to look at this. Again, we're not really getting into this tonight, but I just want you to have the thoughts about all these things that we're looking at. And you cannot forget the eyelids, right? Look, lift, push, pull. It's a good mantra to have because you need to look at the lids, the position, but then you need to lift the lid and look under, right? You need to push on the lids. You need to pull on them. Look at the laxity. Does this patient have floppy eyelid syndrome? Do they potentially have sleep apnea and we don't realize it? And that puts them at other risks. But when you're looking at the glands, you got to look at both the expression, what's the quality, and what is it? What does the glands look like? Do we see pitting? Do we capping? Do we see that the oil that's coming out is grade 1 and it looks like olive oil, like it should? It looks beautiful. Or are we seeing that it looks kind of cloudy like milk? Or is it kind of toothpaste like? And is it really easy to have push out? Or is it very difficult? Those are all good things to kind of get a better idea of where they are with the problem and maybe how aggressive we need to be. Other things to think about, we can't forget about blepharitis, Demodex, looking for saponification, which can be an identifier that the meibum quality is not good. And so that's why we're getting these little soapy bubbles. And then we're looking for collarettes. I think we all hopefully are doing this by now because you know what? They've done a really good job with disease state awareness with Demodex is looking for collarettes. Have your patient look down. It will help you identify them. Okay, so now we've kind of set the stage. Let's actually start getting into some of these new tools that we have in our armamentarium and some that may be coming. So specifically, when we're talking about diagnostic tests, TPOC is a quantitative testing platform, and it actually is looking at two different measurements. It's looking at both the IgE as well as it's looking at lactoferrin. And the idea here is that it helps to identify if a patient has active allergies, which we're going to have an IgE when we have active allergies, because remember, that's what our body is releasing. It's the IgE antibody, and then or antigen. And then with lactoferrin, the different levels of lactoferrin tell us about the quality of the tears, and actually having a normal amount of lactoferrin is good. When we have low lactoferrin, it means that there's actually a suppressed lacrimal function, and maybe an indicator of aqueous deficient dry eye or evaporative dry eye. If we have a high lactoferrin, that's okay as well. It means a normal lacrimal function. So the idea with this testing platform, which is now available for our offices as a point of care testing, similar to adding into what we may already be doing to testing our patients' tear osmolarity, this is just another way to help us differentiate between aqueous deficient dry eye, evaporative dry eye, and is there some allergic component that's there? Now, this is not going to necessarily tell us much about the meibomian quality, or meibomian glands, right? We still have to be looking at those things in meibography, but it is just another thing that kind of helps start differentiating. So we maybe have a better idea of what testing, or I'm sorry, what treatment we want to start with first in these patients. Or say we've got a patient who has both, right? They have IgE and lactoferrin that's low. So positive IgE, low lactoferrin, probably got allergies and aqueous deficient. So now what do I need to do? I need to treat both the aqueous deficient, but I also need to start this patient on something for their allergies, because if I do just one and not the other, I may not truly get this patient to where they need to be. So there it is, food for thought, something interesting, a new platform. Another new testing modality for the office that has come out in the last year, Bruder, and I believe it's I'm going to draw a blank. I'll come back to that. So Bruder, it came out with their own M&S. There we go. I see it on the picture. That helps. So M&S and Bruder are now together. And so Bruder has an ocular surface analyzer, or BOSA. And what this does is it does a number of different tests. So it has 5 tests that it does automatically. It looks at interferometry of the lipid layer thickness. It does an auto non-invasive tear breakup time, auto tear meniscus height measurement, mybography, and auto blink quality. You can also add on other tests. Yeah, if that wasn't enough data, if you want some more data, if you're a dork like me who loves data, you can also look at bulbar redness, fluorescein staining, Listerine, white to white test, and you can do documentation with Demodex and blepharitis. Yeah, that's a mouthful. It's quite a bit. So this is kind of like almost this all-in-one platform for all of these things that we talk about a lot of times on stage and in these lectures. Now, what logistically are you going to use in clinic? Probably the first 5 that I talked about, or even just a few of those. But to me personally, I look at if I'm in the market to buy something new, I want something that's going to have the ability to incorporate more tests that even if I'm not using right now, maybe in 5-10 years or in 2 years, right? We get more data that says, actually, we should be looking at this, and this indicates XYZ, right? So if it was me and I'm in the neighborhood for something new, I'm going to look for something with more bells and whistles that is still in a good price range. And so this one kind of falls in there. Okay, let's talk about actual treatments. With new and emerging ocular surface disease therapies, we're going to actually start with Demodex blepharitis. And a few of these we are a little bit more familiar with. Some of these you may not be. Some of these are, it's good to talk about and understand maybe a little bit of the science that goes with it. So with Demodex blepharitis, this is a study, Titan study, that was actually considers an issue with cholera prevalence in eye care professional clinics in our patients and in very specific key patient segments. Because, you know, as we start talking about it, honestly, were we talking this much about Demodex blepharitis 5 years ago? No. And I think that there's a little bit of wrapping our head around to say, really, is it really that much of a problem? And is it really that prevalent? Or were we really just not looking for it? And honestly, guys, the truth is we just weren't looking for it and weren't looking for it very well. And so now that we are, and now that we have treatments and we have, you know, really good option with lotilaner, it you know, really does behoove us and our patients to make sure that we're looking for this and for treating our patients. So yeah, 25 million Demodex patients estimated in the United States. When you start to break that down, what does that look like in our chair? That means about 7 to 10 patients a week in your clinic have Demodex blepharitis. So I think that's a more realistic number versus talking about 25 million. Now, a couple of new things, because that's what we're here to talk about, right? So we do have plenty of different tea tree oil options. They are already out there. We're familiar with them. My job tonight is to maybe bring a couple of new things that are coming. This is a new wipe. Some of you may be familiar with helpmyeyes.com, which is an online sale platform that you can use. They are actually starting to come out with some of their own products. This is one of them. This is a daily lid wipe that does contain tea tree oil formula. It is not for TPO, which is the one that we have been hearing hit or miss actual studies on saying, is it damaging to my meibomian glands or is it not? It's really inconclusive with the data there, but it is nice to know that no, this one does not. It actually has tea tree leaf oil, along with a lot of the other goodies that we like in our wipes, like the hyaluronic acid, the eyebright, euphrasia, a lot more things. It's preservative free, which is lovely. So an option that's coming. Now, we can also start to talk about the reality of how well does tea tree oil work when we talk specifically about Demodex, right? And the Titan study also did show that tea tree oil and lid wipes are ineffective at treating Demodex blepharitis. I know, right? We know that. But it doesn't mean don't use it. I still look at using whether it be something with tea tree oil or what we're about to talk about for cleaning the eyelids. It's good for daily hygiene and it's good to help control on a more day-to-day basis, along with using lotilaner, which we'll talk about in just a moment. So this is not new, but I do like to talk about it because not a lot of people are aware that Manuka honey actually is well known for its anti-inflammatory and antimicrobial properties. So it actually has a lot of goodness to it. Why specifically Manuka? Well, all honey has methyl glycoxyl, which is what is actually helping with the antimicrobial and anti-inflammatory properties. And specifically, Manuka honey has a much higher concentration of MGO than other honeys, which is where this one really comes in. There was a study that looked in 2020 at 53 participants with clinical signs of blepharitis, and they found that topical overnight application of the eye cream that contained Manuka honey affected significant improvements in ocular surface symptomology, tear film stability, lipid layer thickness, and reduced lid margin staining, as well as Demodex and bacterial load. That's where we're going with this, right? Now, here's the problem, and here's the problem I've had over the number of years. There are not a lot of things that have Manuka honey that I feel are safe to give my patients, because especially in the light of what's happened in the last year with all the drops that have been recalled, the contaminations, the things that we found, everything that's coming out, it's coming out of the woodworks that it's no one I know, it's no company I know, right? Well, there's a new lid wipe with Manuka. So Tear Restore, a company that we are familiar with, that has a couple other products that are out there. They did release their Neutral White Eco, which has Manuka honey in there. Now, Manuka honey is not cheap. If any of you buy it to take for your allergies and things like that, because it's actually good for inflammation in the body, you know, Manuka honey is really expensive. So yeah, these are a little bit more expensive probably than their regular ones, but it's an option, and it's something that we have there that for those patients, because I have them that come to you and say, hey, I read this stuff about Manuka honey. Where can I get this? Can I just buy this drop off of Amazon? Oh God, don't do that. Nope. Here's an option. Let's go this direction, right? Now, another one that you may or may not be familiar with, and again, isn't necessarily new, but I like to talk about because I think it's important to know a few of these smaller treatments that we may not all be doing for Demodex blepharitis for the maintenance. And that's okra extract. And actually, okra extract is an antioxidant, anti-inflammatory, and it is antimicrobial. So it's got all of these good medicinal properties to it. And the only company that I know of at this moment that carries anything that's made from it is Ocular. And they have foams, they have wipes, and they actually have ZocuShield, which is a gel. And they have Zest, which is an in-office cleaning that you can use. And that's specifically for Demodex. And this is a study that was looking at using okra eyelid patch for patients who had Demodex blepharitis in comparison with tea tree oil, right? And you could also say, okay, well, tea tree oil, we know it doesn't really do much. You're right, it doesn't, but it helps. It helps, right? Now, and I'm not talking about any of these in alone by itself. So the results of the study, essentially what it came down to after 3 months of an okra eyelid patch versus a patient who was using tea tree oil cleaner, was that the okra eyelid patch is able to significantly eradicate the ocular Demodex as well as leave ocular symptoms. And it worked as well as the tea tree oil, if not a little bit better. It actually had a lower average kill time for the Demodex than the tea tree oil did. But the bigger thing that I take away from it is some of our patients are actually sensitive to tea tree oil, whether it's the leaf oil extract or the 4-TPO. And so this is less irritating. So options. Now, we have to talk about lotilaner because it's been out now since almost a year at this point. I think it got FDA approval right about this time last year, and then finally got it into our hands, what, about September or so? And so remember, lotilaner is a 0.25% ophthalmic solution that is now FDA approved and available. It is a twice a day for 6-week dosing drop for killing Demodex blepharitis. And this actually works by targeting GABA-gated chloride channels in the Demodex, which we as humans do not have. Okay, so that's why it doesn't really affect us, right? It kills just them. But it's also important to understand it causes paralysis and death of the Demodex mites. It does not penetrate into the eggs, which is why you have to go 6 weeks. That's 2 life cycles, right? Remember, we got that like 14 to 20 days or so. We need 2 life cycles to make sure we kill both the mama and daddy, and then we get the babies once they hatch. And I know it sounds morbid, sorry, but that's why we do that. Overall, endpoints for the Saturn 1, Saturn 2, which are the two studies that were the phase 3 FDA trials, by day 43, looking for a collarette reduction for 2 or fewer. Now, these patients in the study started with grade 3. Grade 3 is about 100 to 150 collarettes per lid. That's a lot. It's a lot. It's pretty gross. And they got them down to 2 or less collarettes per lid. That's pretty amazing. That's really good because we know that none of our scrubs are getting them down there, right? So 50% of the patients got to that endpoint at day 3. I do have the slide. And I think even more meaningful for us for clinic is getting down to 10 or fewer was 81%. Now, this is without any lid scrubs. So for me, what I'm doing in clinic is I'm having my patients start on lid cleaner immediately, sending in the prescription for the Xdemvy, saying, hey, that lid cleaner, that's for life. This is, what we should be doing. You brush your teeth, you wash your face. It's because of bacteria. Same thing for the eyelids, right? So we're going to get you started on good habits to keep this from becoming a problem again. We're decreasing the likelihood. And I'm going to get you on this drop so we can really get those little suckers under control. Okay, switching gears. Keratoconus, wrong lecture. Keratoconjunctivitis, sicca, aqueous deficient, dry eye. So what about these patients? What do we have to look forward here? Well, now some of you may have heard in the last year or be familiar with Aldera and their drug Repro, and please do not make fun of me because I'm not going to say majority of these correct. Reproxalap, 0.25% topical ocular solution. And it is what's called a RASP inhibitor or a reactive aldehyde species inhibitor that is currently being investigated. So it's a completely new system. I'll talk about what a RASP inhibitor is in just a second. Now, what some of us may have heard recently was that unfortunately, they did get a response letter from the United States FDA saying when they actually submitted, they had finished their phase 3 trials in 2023. They sent it in. They unfortunately got a letter back saying, yeah, guys, you got to do a little bit more work for us. So back to the drawing board they did. They're currently, again, in phase 3 clinical trial, looking at it. And the trial is designed a little bit differently this time to help to enable potential resubmission for dry eye disease, new drug application. So they're going to apply again in the second half of this year. And so a RASP inhibitor, and why would we be looking at this? Well, it's different. It's working differently than our other drugs. And it's a pre-cytokine system-based mediator so working on our inflammatory cascade. So if we look at our lovely inflammation cascade, we look at where it's coming in. So we've got our cyclosporin and lifitegrast and corticosteroids coming in and controlling more of our T cell activation. We know we can talk about the LFA1, the ICAMs, all of that. That's already in that area where that would be working. So it actually works higher up in the cascade to start to slow it down. The company is also looking at this for applications because the same cascade and that same area in the cascade is where we start to have problems with allergies. Yeah. So they're looking at other potential applications for this drug in that direction as well. But at this time, they have to finish the phase 3 trials again. Now, looking back at their first 2 phase 3 trials, they actually had some pretty good data. One of the things that was coming out of it, though, was that there was adverse events of reported of stinging. We get that a lot with a lot of our drugs, though, so it doesn't surprise me too much. But looking at the ocular dryness symptom score and seeing that that was improving significantly, statistically significantly, we saw an improvement in Schirmer's test, an improvement in redness, an improvement in all, both of these things for patients. So while it didn't apparently, hit the level that the FDA said, yes, we're good to go, we may still see this coming around and being resubmitted later this year. Now this one, INV 102, so this is Inversa, is the company. And what they're looking at is looking at the treatment of ocular conditions associated specifically with DNA damage. And we get that daily, right? From dryness, decussation of the epithelial cells, damage to the epithelial cells. And we look at how quickly those cells are turning over. So actually you can start to think about neurotrophic keratitis is what that makes me think about when I've got cells that aren't repairing as quickly as they should because the damage is exceeding. And so specifically, this is a modified naturally occurring compound called P53 protein that activates a master regulator of DNA damage response. So it's looking at helping with healing activity and increasing our body's healing activity by essentially kind of kickstarting our DNA response. It's kind of cool. It's very different, right? It's currently in phase 2, but they also have, and this, you hear that and you go, okay, what else could we use it for? Well, they've thought about that. They actually have other studies that are looking the applications for Fuchs as well as adenovirus acute infectious keratoconjunctivitis. So phase 2, so it's already finished. I believe they finished their recruitment for patients, so they're in it, but we don't have data yet. So it's coming. Now this one from Alcon, which I believe they purchased sometime in the last year, but they've already completed both phase 2 clinical trials. Comet 2, I'm sorry, that should say phase 3. They've already finished phase 3 trials. Okay, so this is like awaiting FDA submission and approval. It's ready. It's like it's got all of the data they can. I don't think that they have yet. So this one is a little bit further along in the pipeline and something that's probably going to be coming a little bit sooner. What it is, and they've been kind of quiet about this, right? So got a little information for you, but it's a topical transient receptor potential melastatin 8, so TRMP8 agonist. Now, what is a TRMP8? Let's talk about that. So TRMP is a receptor. It's essentially a corneal surface sensory receptor that is kind of leads to essentially stimulating the function of our lacrimal functional units. So it's helping to stimulate tear production. If we start thinking about that, we've heard LFU with like Tyrvaya or varenicline, like the nasal spray, right? So working to stimulate nerves to stimulate tear production. Kind of my understanding of it. But as they come along, they're going to give us more information. We'll understand a little bit more. But what they found was that yes, in the Comet 2 and 3 primary endpoint that they were looking at was at least a 10 millimeter increase in unanesthetized Schirmer score. And they did achieve that. So that's the data I got, guys. But I think we're going to be hearing about this a lot more sooner than later. Alysta Pharmaceuticals. This is a new name, right? And a lot of times what we see is you're going to hear me talk about this. You're going to see this compound the next 1 or 2 years as it gets into phase 2, 3. Now associated with probably a bigger company that we know, because that's just kind of how drugs work. But Alysta Pharmaceuticals is looking at the ALY688 peptide. And this is a multimodal mechanism of action. So it has lots of different things it's doing. Essentially, it's an anti-inflammatory activity. And it helps to enhance the corneal and conjunctival epithelial regeneration. It is, in theory, going to be a sterile, preservative-free eye drop. And it helps to control cytokines and activated T cells. Yeah, am I being vague? I know I am, because they're pretty vague. I don't have a lot of information on it. But in theory, it also helps to accelerate epithelial healing. As of right now, it's currently in phase 2B and 3. They actually completed phase 2B and 3, which is Oasis 1, but the data is not released. And when I pulled this morning, I checked clinicaltrials.gov. That is what it's listed, just no data yet. Okay, so what do we got coming for our meibomian glands? And this one, we've got a couple of things. One we're going to talk about that already came out last year, but I'm going to talk about another one that I'm actually personally really excited about. Okay, BNL, perfluorohexyloctane. Yep, we got it right now. It doesn't treat meibomian gland dysfunction or evaporative dry eye, right? It mimics the oil. It helps to stabilize that tear film. It helps to decrease the stress on those epithelial cells so that we can have an improvement in both signs and symptoms from dry eye. But remember, this is not actually treating meibomian gland dysfunction. It is just kind of helping us with the downstream effects. And it is 100% perfluorohexyloctane, which is so cool. That's why it comes in such a tiny, tiny little bottle, and they're super tiny. It's power packed full of perfluorine. And it is a semi-fluorinated alkane, so there's no vehicle. It's a stable molecule on its own. It's water-free, it's preservative-free, which means it's pH-free because there's no preservatives, there's no water. It has a 20, I don't think it's a 20 microliter drop size. I think it's actually like 7. I don't know why I have that. It's like 7 or 8. So it's itty bitty. And it has an enhanced surface adhesion. That has to do with the molecule itself. So it's actually, because it's semi-fluorinated alkane, we've got the top of it that is aerophilic, and the bottom is lipophilic. So it helps to keep it upright like a buoy. So what's the top part of our tear film? Oil, right? So lipophilic, the bottom anchors into that. It adheres to the other oil, right? Helping to stabilize. The aerophilic part stays up in the air. So it's helping to stay right there. Kind of cool. It is FDA approved. It's been out, I believe we all finally got our hands on it earlier this year. It did meet its primary endpoints. I think it's always good to know what those were. At week 8, it was looking for the change in baseline in total corneal fluorescein staining. And I found that it was statistically significantly greater in the perfluorohexyloctane arm compared with the control saline group. Now, why was saline used? Well, when you have studies, they're looking at the vehicle versus the active ingredients in the vehicle, right? But when you don't have a vehicle, this is what the FDA decided needed to be used with saline. So improvement in the patient's total corneal fluorescein staining, so improvement in staining, signs, also improvement in their VAS score, which is their symptoms. And they also found that there was a statistically significant improvement in 8 weeks in those patients as well. So an improvement in both signs and symptoms. Okay, so what do we got coming up? We have, there we go, Azura Ophthalmic's new drug that is still in studies right now, I believe, AZRMD-001. If you've been to some of my lectures, you may have heard me talk a little bit about this, and it may be because I'm a little bit excited, and I'll tell you why. So the formula uses the power of selenium disulfide or selenium sulfide. So some of you may realize what that is. Selenium disulfide, the stuff in dandruff shampoo, right? Head and Shoulders. But it's going in an ophthalmic ointment that is applied directly to the meibomian glands in the lower eyelid twice a week. And that is to help with meibomian gland dysfunction. How does it help that? Let's look at that. 3 different mechanisms. Keratostatic, meaning it helps to decrease the hyperkeratinization of meibomian glands, right? Hyperkeratinization, not good because it blocks those meibomian glands. It creates that crust in there that oil cannot get through. It can't help to penetrate. It's a keratolytic. It helps to actually loosen meibomian gland blockages. So it helps to start to loosen that oil that's in there. And then lipogenesis, which actually helps to increase the meibomian gland secretion itself to help promote healthy gland function. What does that mean? It means it might be something we can use for our patients that is a prescription that helps to improve the quality and the expression of the meibomian glands. That can be big, guys. That can be very big. Especially when we know that the other ways that we're doing this right now are out-of-pocket costs to where not all of our patients can get to. Now, I don't see it as a replacement. I see it as an adjunctive. But not going to lie, I am excited to have other options for this. So clinical data, you're finding that it definitely has consistent clinical effect across multiple different endpoints. They're looking at restored gland function. 45.7% of the patients had their gland open to a normal level after use, a 3-month clinical trial. 68.7% of the patients had their meibomian quality return to normal levels. 46.9% of the patients became asymptomatic after 3 months as measured by their OSDI. So we're getting improvement in signs and symptoms for these patients. Again, always important. It is still going through. I think it may have finished phase 3 or it's very at the tail end. So we're not there yet. Coming. Now I am going to mention Cloudbreak Therapeutics. I don't know where they're at, guys. Clinical trials.gov, it says that they have finished phase 2 and they have submitted the results. So it says results submitted. However, when I go to Cloudbreak's website, it's no longer listed. So I don't know what's going on with this. I don't know if maybe somebody's purchased it and it's kind of on the hush hush right now. But the idea is that this is cyclodextrin is the active ingredient, which is a methyl beta cyclodextrin, and it's applied topically in repeat dosing, or it's in eye drops, right? So the idea is would dissolve potential cholesterol crystals deposited in the orifice of the meibomian gland. Again, something that maybe helps to decrease the meibomian gland clogging and improve meibom quality. So we like these. It's interesting, but again, I don't know where it's at right now. Okay. Now let's talk about a couple of devices. I think that these are 2 important devices to talk about when we talk about meibomian gland dysfunction. One is the iDetect ELM, which is the eyelid lipid mobilizer, which is currently awaiting FDA clearance. It's actually a heat mask, but it also has vibrations. Now these vibrations have a very specific frequency that have been figured out using lovely physics that all forgotten in our brain, right? Because we've filled it full of eyeball stuff. But if we start thinking about it, we start to think about meibom quality and why are we melting it? It's because we know that the oil, when it's certain consistencies, it doesn't work well. But what also creates heat? Friction, right? And oscillation, right? And so that makes sense that by having a certain frequency and vibration, that sheer friction actually helps to liquefy and evacuate the meibum from those meibomian glands. Kind of cool, right? The other thing is that this does is it has a neuromodulation. So it's got three bits to it. And that neuromodulation works to mechanically stimulate lacrimal functional unit to help with tear expression as well. So this is, again, still awaiting FDA clearance, but it is something that maybe available. There's some, I think they're kind of trying to figure out where they're going to position this, but I think it may be an in-office treatment that also can be an at-home treatment, or maybe vice versa. Not quite sure. I think it's really being positioned more for our patients to use at home on a consistent basis, which would be nice. And I think that would be more beneficial than coming in once every 6 months to have something done in office, right? Other thing is some of you may be familiar with Nulids, the original, which is on the right, which is the at-home cleaner, the cleaning unit that we have to do eyelid hygiene, right? But now they also have an in-office version that is a little bit different as far as the way that it is put together and essentially the probably the robustness of it. But Nulid Pro has really tried to put together a lot of information to show that, yes, it's so important to clean, whether it be Nulids Pro and having it done in office and having a debulking in that patient who has Demodex blepharitis, that we're then still going to tell to go home and use their lotilaner and clean at home, even maybe with their Nulid home, right? This is another option, and another thing for us to be thinking about is taking care of them in the office. And another bit of data that they're looking at is kind of similar to what we were talking about with the oscillation and the frequency of the meibomian glands with the eyelid lipid mobilizer. but they're kind of thinking that some of the vibration from the cleaning itself and from the unit is maybe causing some improvement in the meibum and the expression of the meibum itself and kind of the liquefaction because of those shear forces again. So things that maybe we ought to be thinking about other at-home more helpful treatments for our patients. Options. Okay, last little bit here, we're going to talk about a couple of things with neurotrophic keratitis and things that are coming this direction. So neurotrophic, let's talk about neurotrophic keratitis. How do we diagnose that? Got to test the corneal sensitivity. At the end of the day, you got to test corneal sensitivity. That's the only way you really know. You can suspect it. Could look like a dry eye patient, could look like my lovely patient here who had, oh, poor woman, hat trick, had a recurrent corneal erosion that then wouldn't heal because she ended up with an active herpetic infection. Wait. And then it got infected and she ended up with a full-on ulcer. Poor patient. She had a tough time, but we got her taken care of, right? And it, though, is one of the things that I love to talk about is neurotrophic keratitis because there are so many more patients out there that have it, stage 1 especially, that we don't realize because we're not checking corneal sensitivity in all of our patients who have corneal staining. Sometimes we do when things don't make sense, but it's definitely a big problem. So I am excited. While the options we have right now are working really well with Sinigerman, I am happy to have more contenders jump in so that I have options for more patients, right? So let's look at what we got coming up that are kind of more close contenders. So Kala, Loda is no longer with them, but they are still in the eye care space. Did you know that? They are, absolutely. One of the things they're looking at is KPI-012-C-001. Yes. And this is for persistent corneal epithelial defect caused by neurotrophic keratitis. And these, it's a novel human bone marrow derived human mesenchymal stem cell that is working to help to increase the function of essentially the nerve endings, right? Is at the end of the day what we're really doing, because it's kind of hard to prove that. I think more of what, we have to look for is similar to what Sinigerman did. They're looking for closure of persistent corneal epithelial defects. And currently, so these patients use it 4 times a day for 8 weeks. And they're in ongoing recruitment for CHASE, which is the phase 2B study. So we're not there yet, but we're going through studies right now. Another one, Claris Bio, CSB-001. So this is actually a hepatocyte growth factor. So if you remember, Sinigerman is a recombinant nerve growth factor. So both of these are different. This is a hepatocyte growth factor. But again, the idea here is to accelerate healing. It's to promote corneal nerve regeneration and reduce nerve damage. And they are still also recruiting for phase 2 clinical studies at this time. This one, I'm not saying this, RAC 0559. That's what you get from me. So the drug itself is a synthetic peptomimetic of human nerve growth factor. So another one going human nerve growth factor, but it's a synthetic. And they are also in phase 2 clinical study recruiting, looking for patients who are either stage 2 or 3. So if you are in an area where people, a lot of times you can go to, you can go to the webs, you can go on the webs and look and find who is actually recruiting maybe in your area for patients for these. I think it's always good to send patients so that we can help, because recruiting for these can be very, very difficult. Sorry. So if you know somebody's in your area that is recruiting for these and you have these patients, call them, find out what the recruiting, and for any of these studies, right? Find out what the recruiting criteria, inclusion, exclusion criteria are, and send patients their direction. It's good for the patient, it's good for us at the long end, and good for everybody else. Oyster Point. So they are also looking at potential gene therapy to help deliver targeted genes to cells using adeno-associated virus, so using virus vectors. We're kind of familiar with that for other things, right? And this is looking at actually helping with the lacrimal gland to help with better secretion of the lacrimal gland. So now that's not necessarily neurotrophic keratitis in the cornea sense. It's the poor functioning lacrimal gland, which actually Sjogren, like I think of Sjogren's patients. I also think of some of my patients who've had certain types of cancer or damage to the lacrimal gland or loss of function of the lacrimal gland. Okay, last one. This is actually a study. It's not being done in the United States. I will tell you I know a couple of doctors, a couple of optometrists who are currently doing this. I had a great conversation on using topical insulin. I've actually talked with my compounding pharmacist, and we've talked about it and if we can do it. But it's already being used outside the United States using topical insulin that's been formulated by compounding to be used as a drop for the eyes. It's already been done in UK. University of Alberta is actually doing a phase 2 study that's recruiting, but last update was 2022. That was a little bit ago. But the idea here is using insulin for the treatment of neurotrophic keratitis. Now, I also know some other people who've been using it very similar to autologous serum for patients who have very severe dry eye, who have Sjogren's, people we have a lot of difficult controlling. And this is not going to be necessarily everybody, right? Because it's compounded. But I think it's really interesting to think about. And it is something that I'm trying to do more digging into and understanding of if it would be beneficial for some of my patients. So come back next year and maybe I'll have some case studies I can tell you about in my own patients.